Welcome, everybody. Good morning, good afternoon, or good night, wherever you may be tuning in today. This is the first episode of my passion project called the EmpowHER the Patient podcast. This podcast series is going to highlight the accomplishments, attitudes, and advice of changemakers in healthcare that are going to be advancing women's health and overall empowering women across Los Angeles. Today, we're going to be talking about a new era of contraceptives. Before I introduce this woman, I just want to say she is one of my biggest inspirations. She is my beloved research PI as well. This woman, when she walks into a room, everyone just silences. And the second she opens her mouth, the passion you can hear in her research, the blood, sweat, and tears she puts into her efforts is very inspiring. This is a woman who is leading clinical research studies in male reproductive health. So, without further ado, welcome Dr. Christina Wang. She is a senior investigator also at the Lundquist Institute next to Harbor-UCLA Med Center, a distinguished professor of medicine also at UCLA, senior associate director and site leader of the UCLA CTSI site at Harbor. And she is a top endocrinologist, specifically specializing in male reproductive systems, hormonal male contraceptives, and androgen replacement therapy and spermatogenesis regulation. So thank you so much for coming on today.
Okay, thank you, Caitlin.
So the first question that I'm going to lead our discussion with is what inspired you to dedicate your career to researching specifically hormonal male contraception?
So it came about many years ago when I grew up in Hong Kong. When I was at the University of Hong Kong, and I was approached really as a young person after training in Australia
Mm-hmm.
by the World Health Organization to do a study on hormonal male contraception. So I was a young, really just finished training, my postgraduate, and then as a fellowship training in Australia. And then I recruited a colleague from the Department of Obstetrics and Gynecology, and the
Mm-hmm.
two of us worked on this project. So this project was designed by the World Health Organization, and then we start from recruitment of the subjects, doing the studies, and which is sort of very interesting because instead of having the patients come to our hospital, which is called the Queen Mary Hospital,
Mm-hmm.
we reached out to them and went to the Hong Kong Family Planning Association clinic. So we brought our lab, very strange lab, and our, of course, the two of us technicians, and started our contraceptive clinic for recruitment once a week at the Family Planning Association. The compound itself we tested was not going forward because of the studies we did. But I remember that the participants, it was so important to hear from the participants because they told us this compound will not work, and surely it did not work. So
Okay.
from then onwards, I was then involved in the World Health Organization in
Mm-hmm.
a way that as a junior investigation into something called a task force for the regulation of um, um, fertility, and was there for a long time. So I sat on an international committee of the World Health Organization for a long time,
Mm-hmm.
looking into the development of male hormonal contraception. So one thing led to another.
Right. That's amazing. I like how you really prioritize your feedback from participants. Can I ask why was it more negative feedback as opposed
Okay.
to
Okay, the compound we were studying was an anti-androgen. In other words, it has been shown in preliminary study works very well.
Mhm.
However, when it works on the androgen receptor. When you decrease the action of the androgen receptor, it decreases the action of the androgen receptor throughout the body, not only the testes, to
Right.
suppress the production of sperm. So it
Okay.
works on what happens is that there's insufficient androgen going into the brain, and the participant told us that this is not going to work because it impaired their sexual activity. That
So
that
I guess moving forward, you had a lot more targeted studies that you wanted to onboard at your site at Harbor. So that's probably like the best. Would you say what was like the best learning outcome from that experience when you were first approached?
Okay, then I think the first thing is that it's really important that you have to support the male hormone, right? The male hormone level in the body
Right.
has to be supported by the exogenous hormones. So what has been, because we learn from the female contraceptive, right? The female
Yes.
contraceptive essentially consists of two components, the progestin to suppress the ovulation, and the estrogen make sure that the woman is not estrogen deficient. And it also works on suppressing um, the product ovulation. So in the male, what we did was that we were going to use initially, studies were using testosterone alone because
Yes.
the testosterone alone will be good because when you give a lot of testosterone in the peripheral, it suppresses the production of testosterone by the testes. At the same time, it suppresses the production of sperm by the testes. So it works because you give the man the testosterone, and you at the same time, because within the testes the testosterone levels are very low, so the sperm concentration is very low. So it works well. It works better in Asian men than in non-Asian men, and those are the World Health Organization that we were working on in that was in the 1990s when we worked on that. And we
Hmm.
thought that adding a progestin may help because the androgen the male hormone levels were high and we're giving more than physiological doses of the male hormone. Then we add on the progestin in the same way like female contraceptive pills, you use the progestin to
And the
suppress,
estrogen. Yes.
yeah, yeah,
Okay.
to suppress the production of sperm, similar like progestin suppressing ovulation, and then you put back on the testosterone. So that works
That's you.
both in all men, and the success rate in suppressing sperm was very, very efficient in many, many studies that we have done.
So, going down this rabbit hole, this is a perfect lead into my next question. Why is it so important to shift contraceptive development towards men? And how is that going to impact our reproductive health equity? Because, like you said, it all started with females. We were the first model, we were the first FDA approval before men, before, yeah, pretty much with hormonal contraceptives in general.
Yes, because the responsibility of contraception has been traditionally rest on the female. So the female is going to get pregnant, and instead of because they don't want to get pregnant at the right time, they can have the choice of use um, uh, uh, contraception at their own choice at the right time, and it is a female control method. Things have changed in the past maybe 20, 25 years in a way that the reproductive health equity is so changed because the men nowadays they want to share the responsibility of family planning. And if you ask them, not so long ago, the Gates Foundation supported a study that was done in 7 countries. 6 of them were in low or middle income countries. And they asked the men and the women who makes the decision to use what type of contraception. Contrary to belief, the
Hmm.
question answer is always the couple. Both the man and the woman take
Hmm.
part in the decision making. Therefore, the participation of men in in contraceptive and family planning is really changed in the past 20 and 30 years. And there are men that would like to participate, and the methods they have were only condom withdrawal, very high failure rate, and
Right.
also is dependent on sexual activity, whereas the well, oral vasectomy, which has been done for many, many years, and vasectomy
It's
is
permanent. It's
often
permanent.
as irreversible.
Mm-hmm.
Although it can be reversed, however, it is often as irreversible because there are significant portion of men that would not regain the fertility.
I see. So would you say that, let's say that your studies progress, and I know you have a study and that's going to advance into phase 3 soon. Um, what would you say are like the first challenges, especially with this new revolutionary drug? Especially there's going to be different cultures, backgrounds, religions that may show some resistance. What would you say about as a researcher, how can you make sure that these drug companies are going to market this drug so that we can reach everyone, especially those who have very little access to contraceptive in general?
Okay, again, I want to refer you back to the study that was supported by the Gates Foundation.
Mm-hmm.
Only in one, they have they have one, they study about over 1,000 or 2,000 couples in the United States, and then they study couples in Southeast Asia, in Vietnam,
Mm,
Asia, Bangladesh, Vietnam. Now I forgot, and then also in Sahara Africa, and so the people in the low income or middle income groups were very acceptable to new methods of male contraception.
mm,
So that the overall when you ask them how many of them would use it in 1 year, essentially it's around 75%, and the highest level were in what a country in one country in Asia and one country in Africa.
I
And
see.
compared to the United States, which is about 40%. If you ask them in their life reproductive lifetime, would they ever use it? The low and middle income countries, it reaches almost 90%. In the
I
United
see.
States, it's better, up to 70%. So the we are not worried about that it will be adopted by by the lower income or countries or less developed countries. The I think the whether it will be introduced into the other country, it depends on the pre-marketing preparation of the country. If you prepare it before you launch your core product, it is almost always acceptable. So they do a landscape analysis, see who may be the potential users, what are the potential users, and then you come to
Yes.
the companies that are developing this um, male contraception. The male contraception, the companies that are developing them are very small. They're
Mhm.
very, very small. And
Yeah.
once they develop product, I do not know whether they have the means to market it or they are going to license it to someone else. The
Right.
develop the phase 3 study is going to be very expensive, and it will be a because we do not know from the regulatory agencies because they never approve a male hormonal methods. We don't know how many men or how many couples we need to recruit and how long they want the couples to stay on this product um, to so that it can reach a regulatory approval. For
Yes.
females, if you base on female, it's 20,000 cycles.
Mm-hmm.
20,000 menstrual cycles is 1,000 couples for 2 years or 2,000 couples for 1 year.
For phase
So
3
we
and
do
female
not know. Yeah.
contraceptives? I
Yes.
see. Okay.
But we do not know. We do not know whether in the for males, if you have a very low sperm count in most of them
Yes.
or low sperm in the ejaculate, whether still require they would require contraceptive efficacy in terms of prevention of pregnancy, I'm sure, but
Mhm.
we do not know how many cycles they would need.
So that perfectly answers my next question about the scientific challenges as they move closer to the market. What about the clinical research side? Would you say that there is a higher dropout rate as like a clinical trial progresses, or would you say it's harder on recruitment? You said that there's something about male cycles that we don't know much about because this is the very first type of male contraceptive that is going to be.
Yeah, the in general, because of the hormones we use, many the progesterone you use have been used by females, thousands, if not many females. Even
Right.
in the compound we have, it is marketed as a vaginal ring, has been used by thousands, if not more. So the compounds are safe, and the male hormone has been around for a long time, and
Hmm.
in the form of a transdermal preparation has been around for over 20 years. So the safety of the male method is not a problem. The recruitment, it depends on what you want to do, right? Because in the early clinical studies, we have very strict recruitment criteria.
Right.
When you go to a phase 3, you may want to relax a little bit. The second thing is that the doing our earlier studies, including the phase 2, is very intensive for the couple. The man comes in at least once a month for 2 years, essentially for 2 years,
I
and the
see.
female comes for a long time. So it is a significant part of the daily activity, and they have to apply the gel every day. And to our sort of surprise, although the gel has been applied every day, and they have to do certain time of the day, and they have to do certain things to prevent the transfer of the gel to the female partner, which is
Exactly.
which is very little in our study,
Hmm.
is a commitment of the couple. So we need the couple to be committed to do this, not just the man and not just the woman asking the man to do it, but the couple has to be willing to do this. So initially, when we recruited the couples, we talk about all this, but once they get into the study, they recognize that you have to develop a certain routine to apply the gel and do the
Yes,
portions. Then some of them, they did not realize what happened, that it really has to adjust the lifestyle so that they can use this thing very well. Once they get it, once the couple have developed a schedule for themselves, it works really well. So once the male and the female develops a schedule, incorporate it into the daily activity, including the exercise schedule, the shower schedule, uh, and the work schedule. It works, in fact, very well, to our surprise. The couples love the gel, both the men and women, they like the gel. It is applied and you don't see it, there's not a patch, and you don't go to the doctor's office, you do it on your own, which is really important because it's user control, right? It's not you have to go to a doctor's office. If you don't
exactly.
go, then we call you. This is
Autonomous,
they have to
yes.
apply themselves. So the
Yes.
user control methods usually have a higher failure rate as well as drop, of course, right? Yeah.
Right. So for people that are tuning in, that don't really know about this topical, could you just give like a brief explanation? Like it is a topical and it's supposed to be transdermal, but you can't get it on anyone else. Could you explain more of why it's very important to
Yes.
develop
The
a
gel is
strict routine?
the application of the gel is very easy. We at the present moment we have asked them to apply on the
Okay.
shoulders and upper arm, and the gel dries uh, within a few minutes without any residue. You cannot see it.
Hmm.
However, the gel is absorbed. About 10% of the hormones are absorbed into under the skin.
Hmm.
And when it is absorbed under the skin, it makes a relatively stable level of the hormone. That's the advantage of the transdermal gel. instead of after injection or oral medication, you have very high peaks and then it comes down the levels.
Right.
Whereas with the gel, the levels of the when it goes transdermal, the levels of hormone are relatively stable. Big advantage.
I,
However, the gel there that remains on the skin, it will remain there until it's washed off. So when the exposed area is in close contact with anyone, in close skin contact, there is a risk of secondary exposure of the person not applying the gel to these hormones.
I
So
see.
we show in studies before the main study that it will be prevented by wearing a t-shirt because a t-shirt, um, wearing clothing, or that you wash before close skin contact. So that's the instruction we give to the couple.
Mhm.
So that's why they develop a schedule and they can work with it and they do not think it's surprising that they do not think that this is a problem.
I see. That is great. So, what is like one short story that you could share with us just about the female perspective of a couple enrolled in a trial like this?
Okay, so there this I mean just this is impression of us uh,
Yeah.
uh talking to a couple. We have questionnaires. We have questionnaires that are given to the men and the women to fill in during different periods of time, and that has not been analyzed. As well as at the end of study, there were in-depth interview to confirm that by an investigator who's trained to do that, and this person would call the couple, and if they are willing to talk to the female, talk to the male, and then couple together, those data are not available. From
Mhm.
impression, from the impression that we deal with the couples, which we have around 40 that's enrolled in the study, the female has no problem once they develop a schedule. The female likes it because they like it because they do not have to use contraception once
Yeah.
the sperm count is suppressed to very low level. And they also like the man taking responsibility again. And whether the man, why the most important is the female, whether female trusts the man, we do not know from our study, but from the study that I mentioned, supported by Gates Foundation in 7 countries,
Hmm.
the women trust the man, had no problem in trusting the man. Over 85% of the women would not worry about that only the man is taking the contraceptive gel. So all
That is amazing
interview.
data. Despite it not being available, the interviews are going to be interesting, but I feel like the women are just going to be feel a lot more relieved, especially with not too many female contraceptives really, I guess, like being compatible with someone's body. There's a lot of different types of contraceptives, different estrogen doses, progesterone doses out there that
Yes.
can cause you to break out on your skin or cause you to gain weight or lose weight. And it's very frustrating for women. It causes so many mood fluctuations that could affect your relationships with other people and how you may go to work or how you might not like your hobbies anymore. There's so many problems that I could think of day to day, just from what my generation tells me. And yes, they do offer it. It's interesting how they offer it for period cramps too. For me personally, I had very severe period cramps where I couldn't get out of my bed, and I had to take female contraception pills for that. But it caused my skin to look horrible, so oily. I had to get so much new Korean skincare. You see, all of these things, all these side effects that men don't really consider when we are trying to switch pills, trying to figure out for months at a time, too, you have to allow the pill to really take action on your body and you could really see it. You don't know what's happening inside, but when you start to notice these negative side effects, it's very frustrating. So that is why I am a very big advocate for this cause, especially because,
Yeah, but there are many delivery systems, right? The um, vaginal devices, right?
right,
Rings and
IUDs, yes. Mm-hmm.
Intrauterine devices are very long acting, very, very effective. The intrauterine and the delivery of the hormones are much, much more smaller than the oral contraceptive pill. There's also the patch that you can use
Right.
that the delivery is much more constant, and therefore you won't have the peaks and troughs, and you give you maybe less side effects. So there are many, many options. For the male, that's what we want to do, to have many options.
Right.
Yes.
That is true. So thank you so much for your time, first
Okay,
off.
thanks.
Yeah, I
Thanks for helping me.
genuinely
Nice.
appreciate. Sorry,
Okay.
what was that?
Thank you. Bye.
Yes, bye. Thank you.
Bye.
So, thank you so much, guys, for tuning in. That was an amazing first episode. Like I said, this is the first of many episodes that we are going to be recording on the Empower the Patient podcast. But we were joined with a very special guest today, and we are super grateful for her time. This is going to be season one, episode one, concluding, but we will see you next time with many other special guests that are going to be our change makers that are advancing women's health and empowering the female patient population across Los Angeles. So thank you very much, and we'll see you next time.